A regular heart rhythm is essential to your health. It ensures your heart delivers the necessary nutrients and oxygenated blood to the tissues, organs, and cells throughout your body. Rhythms of your heart tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Kelly Evans-Hullinger, and tonight we will be talking about cardiovascular heart health, specifically the rhythm of your heart. The rhythm of your heart plays a crucial role in your cardiovascular health. A normal, steady heartbeat indicates that your heart is functioning properly and efficiently pumping blood throughout your body. Irregular heart rhythms, also known as arrhythmias, can disrupt this process and lead to various health problems. If you experience any symptoms of an irregular heartbeat or suspect a heart rhythm disorder, it is important to seek medical attention for proper diagnosis and treatment. Tonight, we will discuss the rhythm of your heart and how it affects your cardiovascular health, and take viewer questions. Thank you for joining our discussion. This evening, we are joined in the studio by Dr. Paul Olson and Dr. Jonathon Adams from North Central Heart and the Avera Heart Hospital in Sioux Falls, South Dakota. Welcome, guys, and thank you so much for joining us this evening. Dr. Olson, tell us a little bit about yourself. How long have you been practicing in Sioux Falls, and what do you do?
I've been practicing in Sioux Falls since 1991.
Yeah.
Do heart rhythm work, electrophysiology. We see patients in the clinic with heart rhythm problems, do procedures, pacemakers, defibrillators, some ablations, and see people in the hospital. Just about anything that deals with the heart rhythm.
Yeah, thanks for being here.
Mm-hmm.
And Dr. Adams, where are you from and how long have you been back in Sioux Falls?
Yeah, I grew up in Yankton, and I went to SDSU here in Brookings, and I've been back in Sioux Falls since 2014, practicing with Dr. Olson. As far as the training went, I spent 6 years through the Mayo Clinic system and then 2 years out in California at Stanford, and then came back to practice here, closer to family, that kind of thing.
Yeah, and also an SDSU grad, Dr. Olson? Yes, all three of us, excellent, on campus again, so that's great. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about cardiovascular rhythm. Viewers can contact us in 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. Let's start by talking about probably the most common thing that I see in primary care that's a heart rhythm problem. That would be atrial fibrillation or AFib. Is that the most common thing that you see in your clinic too, Dr. Olson?
It is. It's the most common heart rhythm problem that we deal with.
Yeah.
It's a rhythm where the atria go very rapidly, about 300 or more beats per minute, irregular to the ventricles. There are a lot of risk factors for it: increasing age, increasing weight, sleep apnea, alcohol, tobacco in some people, family history in some people. The main risk is associated with potentially a blood clot or a stroke.
Sure.
And then can cause some other issues, congestive heart failure in some people, symptoms for sure.
Yeah. So what symptoms do people present with AFib most of the time, Jonathon?
Well, it varies.
Yeah.
Surprisingly, like most people say, I've had even referred from doctors say that I don't feel my AFib, but they notice that their energy levels are lower, their stamina is reduced. They feel more short of breath with activities. And a lot of times patients, because it's associated with aging, they'll just write it off and say, I was just getting older and now I've just been feeling more tired, and they don't realize that it is potentially their AFib.
Yeah.
I've got other symptoms, heart racing, dizziness, sometimes chest pain.
Yeah. Anything else that you've seen? as far as symptoms?
I agree with the lower energy, stamina, and a lot of people, like you said, attribute it to aging, and then a lot of times we find out it's the rhythm. Once we get the rhythm back to normal, it corrects that, and then they find that they do feel significantly better, even though they weren't necessarily aware that it was bothering them.
Sure. Sure. And you mentioned the risk of stroke. Why is that? Why is AFib a risk of stroke, Jonathan?
Well, so like Dr. Olson was saying, when people go into atrial fibrillation, the upper chambers of the heart are beating so fast that there is no real effective contraction to move the blood through the upper chambers of the heart, and the blood flow just becomes very stagnant. And if that happens, the blood can start to coagulate or form into a blood clot. If that blood clot breaks loose and gets pumped out of the heart, it can go to your brain and cause a stroke.
Yeah, yeah. So a lot of patients, we do recommend blood thinners, right?
Correct.
Well, yeah. Are there alternatives to blood thinners? Or, I mean, blood thinners for a lot of people, but
So it started with warfarin or Coumadin one, many years ago, which was harder to manage because you had to have the blood test done regularly. Then they moved to newer agents. There's Pixaban or Eliquis, and then some others that you don't need to have blood test monitoring, so they're newer, a little bit safer.
Right.
And then there's a device that can be placed in people that have difficulty with the anticoagulation called the Watchman device that Dr. Adams does.
Sure.
That you could probably comment on.
Yeah. What types of patients might be a good candidate for that? Because a lot of people do well on blood thinners.
Right. There you go. Yeah. Blood thinner. And so blood thinners right now, the kind of the mainstay is the gold standard for stroke risk reduction. As it stands right now, we put Watchman devices in people that have risk factors for stroke but can't tolerate the blood thinner for some reason. Usually it's frequent falls, bloody noses, GI bleeding, stuff like that. There is a trial that has been enrolling, looking at what would happen if you gave someone a Watchman that did not have an intolerance to a blood thinner, and what those outcomes are. But for now, it's just people that should do something about their stroke risk but can't tolerate the blood thinner.
Got it. Well, that's good. I'm sure we'll have more questions about AFib, but we'll get to some viewer questions that have been coming in. We had an email question. My sister is set to have a pacemaker in 2 weeks, and I'm going to take care of her after surgery. What does recovery look like? So I guess let's back up. Why do patients get pacemakers? Paul?
Most of the time it's for a slow heart rhythm. Some heart rhythms that are slow can be serious. Some are not serious, just cause decreased quality of life, maybe dizzy spells or lower energy, stamina. So then the pacemaker can pace the upper and or the lower chambers and increase the heart rate. So improving quality of life in many people. In terms of care afterwards, it's not a whole lot to it. They just need to be cautious with the arm that on the side of the pacemaker is placed, and pretty much normal recovery after that. It's much less recovery than it used to be in the past.
Yeah. What is the procedure like? Like, what is a pacemaker, and how do you put one in?
Well, the standard pacemaker, it's a device I tell people it's about the size of a wristwatch, and we make an incision. I usually use their non-dominant side, kind of up by their shoulder. The only reason we make an incision is just so we can tuck the device underneath the skin. Everything else is done through the veins, and we just float a couple of wires, one to the lower chamber, one to the upper chamber of the heart, plug them into the device, put that underneath the skin, and then just close it up, usually dissolvable stitches. And then I would add to, like, what's the recovery look like? The biggest thing is making sure that incision heals well, because we really don't want that getting infected.
Yeah. Good to know. We had a Facebook question. I have been asked to wear a heart rhythm monitor. Do I need to press a button when I have symptoms, or does it automatically gather that information? Let's talk about heart rhythm monitors. You guys probably use a ton of those. We use them a lot in primary care too. What types of monitors do we have? I guess, like, what types of devices? And then I guess we can answer the question about signaling symptoms. What would you advise?
Right, so this patient's probably talking about wearing like a monitor that we stick on their skin. The ones that we use the most commonly these days don't have any wires. They used to have wires that people would put on and take off. The ones that we use, no wires. They usually stand for about 2 weeks. And there is a button you can push, but I would say for me as a physician, the most helpful thing is if you're having a symptom like dizziness or shortness of breath or something like that, there's a diary that goes along with the monitor, and if you can indicate your symptom, then we can pair that up with the rhythm at that time, and we can see if that rhythm is causing a problem. One of the things about the devices is the button is like right on the device, and sometimes patients bump the device, you know, and so we never know if that button when they pushed it was really intentional or not.
Got it. So use the diary or journal that you're given. And so when someone wears this device for however long, 14 days or whatever, and then what kind of information do you get? What are you looking at? How are you giving a report on something like that?
It comes back with a kind of an analysis from the company that we then interpret and look over. It shows the kind of the average heart rate, the range of heart rates. It shows abnormal rhythms from the atria or ventricles, premature beats, slow rhythms, and then shows the tracings of all these events, whether they're triggered by pressing the button, diary events, like Dr. Adams was saying, it'll show tracings of those to tell us, you know, what was the rhythm at the time of those. Shows if there's atrial fibrillation going on, how much of the time it's there, what's the average rate. So it's a lot of information that's very helpful, and it's a lot more convenient than the monitors with the wires, because it's up here, people can pretty much do what they would normally do.
Right. You can go about your normal life, and you can wear them for longer than the old monitors too, right? Yeah. Good. We use those a lot, and they're pretty informative. So great. We had an email question to kind of tag on to our initial discussion. My husband has AFib. What is his risk for stroke? So Paul, not all are created equal, right?
That's right.
Like how do we assess people's risk for stroke, and who should be on a blood thinner?
Well, there's that kind of complicated. There's a set of guidelines that look at the different risk factors. So if age, at least 65 is one risk factor, 75 is counted as two risk factors: congestive heart failure, high blood pressure, diabetes, vascular disease are some of the different risk factors. So the more risk factors a person has, the higher their risk. If a person has none of those risk factors, the risk is very small, probably 1% per year or maybe less. If a person has several, it could be 4, 5, maybe 6% per year without the anticoagulants or blood thinners. If the risk is high enough to warrant the blood thinners, usually they say maybe 2% to 3% per year, then the blood thinners will lower that risk by about 2/3, roughly.
Yeah, good. So that's a tool that your primary care provider or cardiologist can use to help you make a good decision about that. But we do that in all of our patients, so it's a great question. With an email question, what's the difference between heart palpitations versus heart arrhythmias? So I guess heart palpitations are a symptom and an arrhythmia is more of a diagnosis. So what causes heart palpitations that's not an arrhythmia? I guess let's start there.
I should defer to Dr. Olson on this. You know, I just saw a patient earlier this week that had palpitations, and they wore a monitor, like we talked about, and they had multiple episodes where that was their symptom and their rhythm was normal.
Right.
And they wanted to know, well, what caused that? Well, I mean, I don't know for sure always. You know, we don't always know. But we do see that not infrequently.
Right.
Sometimes it's anxiety, sometimes it's, we were talking before, drinking too much caffeine or something. I mean, or stress or something like that. It's hard to know, but but if you record your rhythm when you have the and you have the symptom of the palpitation and your rhythm is normal, sometimes that's actually reassuring and patients feel better.
Yeah, helpful for all of us to know that. Anything to add to that? Yeah. I feel like I wonder sometimes in my patients who have palpitations, I might make them wear a monitor and they don't have any arrhythmia, but they have maybe a lot of premature beats, and I wonder if they have more of a sensation than the average patient.
Yeah, a lot of people. Yeah, some people have lots of premature beats and have no symptoms. Some people have very few and have symptoms like they often describe like flutters or skipping or thumping or pounding in their chest.
Yeah.
If it's not very frequent, those aren't serious. Right. A lot of times the main intervention is just to reassure people that it's not serious, not going to hurt their heart, and that they're okay, basically.
But those heart monitors are nice because that's really the only way for us to get that information reliably. So great. Let's see here. A caller from Sioux Falls. Can sleep deprivation or other sleep problems lead to greater risk of heart problems? Or what impact does sleep have on heart health? So what would you say to that, Jonathan?
Well, from the standpoint of AFib, we know for sure that there's a correlation between untreated sleep apnea and atrial fibrillation, especially like the progression of AFib. So as time goes on, people start to have more and more atrial fibrillation. The episodes last longer, they're more frequent, and that tends to happen faster in people that have sleep apnea and don't treat the sleep apnea. So if you're getting poor sleep, yeah, I mean it's a stressor on your body, and I would expect you to be at higher risk to have things like sleep apnea, atrial fibrillation and stuff.
Yeah, so sleep apnea, we definitely have good data on that, yeah.
And sleep deprivation, I think, also can be associated with a higher risk for other cardiovascular problems too, potentially. Yeah.
Good. Let's see. My husband says he hears a whooshing sound in his ears, mainly in a quieter setting, even watching TV. What is causing this, and is it related to his heartbeat? I get this question from time to time. I hear my pulse in my ears, and sometimes it's alarming to patients. Is that something that you've ever seen correlate with anything concerning,
Usually
Paul?
not the heart rhythm.
Yeah.
It could be something with the vessels or something else that might need to be checked into by another field, but almost never something with the heart rhythm, though.
Yeah. Good. Yeah, I don't usually have a good answer for that either for my patients. Let's see, we have some other questions. This one's from Facebook. I have high cholesterol, but I am worried about taking statins as I have concerns about the increased risk of diabetes. Do the benefits of lowering that cholesterol outweigh the risk of diabetes? So I know this isn't, your bread and butter always dealing with the cardiovascular risk, but what would you say about statins?
The short answer is yes. The benefits outweigh the risk in people that have a higher risk. So there is a little bit more chance for diabetes in people that take the statins. I've heard some experts comment that it's not necessarily that it causes the diabetes, but it kind of unmasks it, so it may show up earlier than it would have otherwise. And so there's a substantial reduction in like heart attacks and strokes and vascular disease complications in people that take statins when they lower the LDL, the bad cholesterol, significantly. So the benefits of that clearly outweigh any potential risk for earlier onset of diabetes, yes.
Yeah, statins kind of get a bad rap. I feel like I have a lot of people coming in really reluctant about statins. How do you help those patients in your clinic if you're trying to coach them through that?
Well, full disclosure, I don't get a lot of questions about statins in my clinic. But I think I just encourage them to try it, and if they have issues with the statins and they really do have a cholesterol problem, there are other solutions to that as well. These days.
Just that there are studies that looked at people taking statins and having muscle symptoms, and then placebo-controlled, so they're taking like a sugar pill. Some people on the sugar pill got the muscle aches, and some people on the statins didn't, and they crossed them over, and it could go either way.
Right.
So there is some incidence of muscle symptoms, but it's not as high as I think the lay literature would suggest that it is.
Yeah, and I always encourage my patients to not give up on the statin. If you do have muscle aches, usually we'll give it a stop and retry, or try a different one or a different dose or something. You can usually get beyond that.
And red yeast rice actually contains a statin.
Yeah, it's not better in any way, right? It's probably just a weaker.
So if you tolerate
similar
that,
side effects,
you probably tolerate that.
Yeah, good advice. Let's see, we had an email question, great question. Can children be born with irregular heartbeats, and is there are there reasons for children to get pacemakers? Do either of you see children, or?
Not really.
Yeah, that's a small
teens.
subset of
late teens.
Yeah.
I mean, babies can have like extra electrical pathways and have certain types of like supraventricular tachycardia, rapid heart rhythms. If they have congenital heart disease, that's a structural problem, they're more likely to have heart rhythm problems. So yes, children, even sometimes babies, rarely though, may have a need for a pacemaker. That's problematic as they grow, but it can happen, yes.
Right, yeah, good. Probably rare disorders in babies already under the care of a very highly specialized cardiac team, almost always, right?
They had dedicated like pediatric electrophysiologists at Stanford where I trained.
Yeah, great. Well, pacemakers are small, implantable medical devices that regulate a patient's heart rhythm. Prairie Doc spoke with Dr. Riyad Mohama, a cardiologist and electrophysiologist at North Central Heart and Avera Heart Hospital in Sioux Falls, to find out more information about this technology.
A pacemaker does have a battery that lasts anywhere between 8 and 12 years. And it delivers a tiny pulse to the heart to make it beat. Usually the pacemaker is implanted in the shoulder area, either side, with a wire that's connected from that pacemaker, and it's in the heart. Most of the time, we implant pacemakers basically for individuals who either passed out or have fainting spells, or if they have been having problem with slow heart rate.
As people grow older, their hearts begin to weaken, and signs may show that a pacemaker is needed. If a person's heart beats too slowly or pauses, they may need a pacemaker.
Pacemakers came a long way since the 1950s. It used to be large devices. Obviously, technology improved. The longevity for the device increased. The size of the device has come down. Basically, for the past probably 10 to 20 years, the size of the device has not come down significantly, but we have had improvement on the various functions of that pacemaker. So it can accommodate patients' activities, situations like if they are resting or active, the maximum heart rate that they can reach, issues like these. And they can recognize when some abnormal rhythm that might happen in the heart too.
After recovering from the implantation surgery, patients can usually return to their normal life with little to no restrictions.
Indeed. I mean, contact sports, aggressive type of sports would be an issue. I mean, we have had pacemakers implanted in police officers, and they still continue to do their work. Athletes who run, do some mild activities, even jumping, that will be all right. But contact ones that will have a direct trauma to that site with that pacemaker may be an issue that we usually advise not to be involved in. And as I was saying, I mean, technology is advancing. Who knows? Probably in the future we will see more and more of those tiny devices that are implanted, and all for the benefit of the patients.
Great, thanks for that segment. Let's talk a little bit more about pacemakers, because this is a common thing that you both deal with. We've got some figures here. Can you kind of just show us a typical pacemaker, where it affects in the heart, and what are those kind of key things to know?
Sure. So the pacemaker is a device, has been mentioned, that's about this size, and it goes under the skin, just under the collarbone area here. This just shows the leads going into the vein. So when we place them, we place the leads into the vein. They go down into the heart. Typically one goes down into the right ventricle here, one goes into the right atrium up here to deliver pulses, electrical pulses, to stimulate the atria and or the ventricles. Or if the heart rate is rhythm are okay and the rate is normal, then it can just monitor the rhythm, just be basically on backup and on demand.
Yeah. And we talked a little bit about, these are pieces of technology that have really improved. They're smaller, they're better in some ways, right, Jonathon? I mean, how have things changed in the last 5 to 10 years with pacemakers?
Well, I'll speak about the last 10 years.
Yeah.
So, when I was first starting, it was a big deal that pacemakers, you could have an MRI with your pacemaker, so all the modern pacemakers that are available are all MRI conditional, so you can have an MRI scan done even though you have a pacemaker or a defibrillator, matter of fact.
Sure.
Pacemakers, like I was telling you, pacemakers are smarter. We always like to try to program them so they only pace when they need to, they don't overdo it, so it doesn't waste your battery. It doesn't, if you pace the right lower chamber exclusively too much, it can actually worsen your heart function, so we want to minimize that. There's newer algorithms programmed into the pacemaker that make that less. Batteries are excellent. That's a big question, is how long do they last? Usually 8 to 10 years, depending on how much you pace.
Yeah, great. Yeah. And while we've got the figures up, do you have a figure that would just kind of show us what's the normal electrical pathway of the heart, and then maybe we can talk about where some of those abnormalities come up. Paul?
The normal electrical signals start in the upper chamber on the right, the sinus node. They go once and travel through the atria, then they go through the atrioventricular node, and then down to the ventricles. traversing the right bundle branch here to activate the right ventricle, and then going down the left bundle branch to activate the left ventricle here.
Yeah, great. And we got a question about what is a left bundle branch block, and so someone might see that on a readout of their EKG or have been told that. What exactly does that mean?
So this is, again, the left bundle branch here. So left bundle branch block is where the electrical impulses stop conducting through this pathway here, the left bundle branch. So when they activate the ventricles, the signals will get through the right bundle branch okay, but then it will take longer to get to the left ventricle. So the left side of the left ventricle can be activated later, so the heart can beat a bit less synchronously sometimes. And if that can cause the heart to be weaker in some people, not always. Some people can have the left bundle branch block, normal heart strength. If the heart is weaker, then an option can be to place a pacemaker with, or defibrillator that has leads on the right side, and then one that goes in a vein, then over to the left side of the heart to pace both sides together. That can often then improve the strength of the heart.
Yeah, it's a cool thing that
very helpful.
To see that in action. So great.
I think one thing I'd add there is that just because you have a left bundle branch block doesn't mean that anything has to be done.
Right.
There's lots of people out there with left bundle branch blocks where their heart's normal, they have no symptoms. It's just something to kind of be aware of and keep an eye on.
Yeah, good. Well, we have plenty of Facebook and caller questions, so we'll get back to those. We had a Facebook question. The question is, what can be done when a cardioversion is not successful? I guess let's start by what's a cardioversion?
Yeah, so
what does that mean?
A cardioversion is essentially when you shock the heart, usually from atrial fibrillation or some fast heart rate, to get it to go back to normal. I tell people it's like resetting your heart, okay? And we do use a shock, and it's a big shock, so we have to sedate patients before we do it. If someone comes in and they've had atrial fibrillation, for instance, and it's been going on for a long time, sometimes we do a cardioversion and they're only in normal rhythm for a few seconds or a day or two, and then they go back to atrial fibrillation. In those cases, depending on how they felt when they were in normal rhythm, we could redo the cardioversion with a medicine on board that's supposed to make it harder for the rhythm to go back into atrial fibrillation.
Yeah.
Or sometimes we do an ablation procedure to prevent the atrial fibrillation from coming back.
Yeah. So you use it sometimes to help you understand how much of your symptoms are being caused by the AFib? I mean, is
Correct.
that helpful?
Like that patient that comes in and they're just feeling more tired and they got AFib and they don't know, am I just getting older or is it from my AFib? We'll do the cardioversion, get them back to normal rhythm, see how they feel, and if they feel a lot better and their energy's improved but then the AFib recurs, then we give them specialized heart rhythm medications or we do an ablation procedure.
Yeah, good. That segs into another question we had. Let me find this. It was a question about options for treatment for AFib because there's a lot of different options. I guess let's talk first about medications and medical strategies. How can we help people with AFib with medications, first of all?
So the first issue to address is the risk for stroke, which we talked about, and lowering that risk. And then the next question is often, should we try to get the heart back to the normal rhythm, or should we let the heart stay in atrial fibrillation? Studies have suggested that it's beneficial and lowers the risk for certain adverse events to try to get the rhythm back to normal and try to keep it normal. So the trend has been over the years to try to keep the rhythm normal for most people. So then it can sometimes involve this cardioversion first, sometimes then involve the different heart rhythm medications. Some can be started outpatient, some started in the hospital. And they reduce the risk by about half to 2/3 of atrial fibrillation coming back. So they're helpful, they're not completely effective.
They're not perfect.
Not perfect.
We have medicines sometimes that just keep the heart rate from going too fast. We have these ones that try to keep it in a normal rhythm. We have cardioversion. And then I guess let's talk a little bit about an ablation. What's an ablation? A lot of people have heard that term.
Yeah, so an ablation is a procedure where we intentionally damage parts of the atrium, muscle cells in the heart to prevent the bad rhythm from recurring. And so in atrial fibrillation, that's usually the left upper chamber of the heart, kind of where the blood vessels from the lungs connect to the left upper chamber of the heart. That's often where extra heartbeats come from that trigger the AFib. And so we put catheters in the veins in the legs up to the heart and direct them out towards those areas, and then we ablate those areas. When we say ablate, that just means we're trying to injure those cells permanently, make them turn into scars so they can't create extra heartbeats that then trigger the atrial fibrillation. Historically, we would use heat or freeze those cells. Over the past almost year now, we've been using this pulsed field ablation. It's kind of a really fancy new technology that doesn't heat the tissue or freeze the tissue. It just delivers these really specialized shocks to the muscle that makes the cells die off without injuring anything else.
Yeah, and I think we have more on that later.
Yeah.
What's the success rate of an ablation for atrial fibrillation?
It depends on the type of atrial fibrillation. For the atrial fibrillation that starts and stops on its own, typically I see in studies like 60, 70 or so percent success with one procedure. If atrial fibrillation is more persistent, just there all the time, one ablation, maybe 50-ish percent, somewhere in the 50s. So often it takes medications along with the ablation when the atrial fibrillation is more persistent.
Got it. So it may not be, you may not be done with after the ablation.
Right.
So there's been kind of a little bit of a shift too in exactly what your definition of success is. So when you say what's your success rate, so historically the success rate was basically 0 atrial fibrillation. And more recently, last couple of years, they've gone to what's your atrial fibrillation burden before versus after. And so how much do you reduce that atrial fibrillation burden? So say you were in atrial fibrillation 50% of the time before the ablation, and afterwards you're in atrial fibrillation less than 1% of the time. That would be a failure in the old days, and it would be reported as like a 49% reduction in your AFib burden these days.
Yeah.
So there is definitely an effect. It may not always be curative.
Yeah. But that's probably why I have patients come in and ask me, well, I had my ablation done last year. Why am I still on my blood thinner? It's because we expect a lot of patients will still have some atrial fibrillation. Is that true?
That may recur, and then the studies have not yet proven that the ablation lowers the risk for a stroke. There's some suggestions, but not proven yet to where it's safe enough to stop it. The main reason to do the ablation is to try to keep them in normal rhythm, can reduce potentially some adverse events, and then also mainly help with quality of life symptoms. Yes.
Yeah, good. On top of that, we had a caller who said they were diagnosed with atrial fibrillation, but they're afraid about taking blood thinners. How do blood thinners work, and what are the side effects that they need to worry about? And I mean, this is probably a common issue that you address with your patients.
Yeah, the side effect is bleeding risk. But we kind of assess that. The bleeding, that's what that whole risk assessment is all about, is what is your risk of stroke if you don't take it versus your risk of bleeding if you do.
Right.
And generally that is if your risk of stroke is 2% or more per year, then you're better off taking the blood thinner. Now obviously there's certain people, you have to individualize your recommendation. Someone who has a history of GI bleeding or something like that, you might say, well, your risk is probably higher than the people that were in that study.
Right.
Now, how do they work? Well, the modern blood thinners, they block components of the clotting cascade. They're different from medicines like aspirin. We get a question a lot about what about aspirin versus Eliquis or Xarelto or whatever. And so there was a study of aspirin versus one of the main blood thinners that we use, and the stroke risk reduction in atrial fibrillation from aspirin is very minimal. It's like 10% or less. Versus with the modern blood thinner, it's like 65 to 70%. And the bleeding risk is actually very similar between aspirin and Eliquis.
Yeah. A lot of people think that aspirin is going to give them less risk, but we see a lot of ulcers because of aspirin. So, I
have some people too that when we use the term blood thinners, it's easy to recognize. People know what we're talking about.
Right.
They actually don't thin the blood. They don't change the viscosity, which is made up by the red blood cells. So some people may think that it changes how they feel or how their blood flows. The blood flow is the same. It alters the blood clotting factors to lower the risk for a blood clot or stroke. But the blood flow is exactly the same, so people should feel the same essentially on these anticoagulants.
Yeah, good point. And I always also emphasize when people are worried about the bleeding risk that a stroke is a very devastating thing. It's hard to compare that risk of stroke to the risk of a nosebleed or a lot of the bleeding events that are not a fatal or life-altering thing. So, good conversation. Well, atrial fibrillation is a heart rhythm disorder which involves disorganized electrical signals within the heart. This disorder, also known as AFib, can be treated using pulse field ablation. This procedure uses electrical pulses to disrupt the arrhythmia of the heart, working to get both the upper and lower chambers of the heart back in sync. Dr. Chris Stanton specializes in electrophysiology at North Central Heart and Avera Heart Hospital in Sioux Falls. He spoke about this unique procedure used to treat a common heart issue.
Patients who are symptomatic from their atrial fibrillation may come and go, or it may come and stay. Not everybody feels their atrial fibrillation, but some people feel tired or fatigued or feel their heart beating abnormally. Patients who are symptomatic are people that we consider for this procedure.
AFib has several treatment options. Stanton says that he has been performing pulse field ablation procedures for patients since May 2024. This procedure selectively destroys heart tissue that disrupts the electrical pathways that cause AFib.
Traditional energy sources for treatment of atrial fibrillation had some dangers. There was risk of collateral damage to either the esophagus or the nerves that control the diaphragm, called the phrenic nerve. Traditionally, we had to watch out for heating or cooling damage to those structures. PFA is unique, pulse field ablation is unique because it's tissue selective and it only kills the tissue that we're trying to kill.
Stanton says that up to 80% of patients who undergo this procedure experience long-term improvements from atrial fibrillation.
The atrial fibrillation episodes tend to occur less frequently, last a shorter amount of time, and be better tolerated.
Stanton demonstrates how he performs the surgery and shows what equipment they use to complete it.
Inside the heart, if you imagine this is sitting in a ball, there are 4 structures called pulmonary veins. We engage those with a wire, and then we advance this catheter over the wire into the vein, at which point we configure the catheter into 2 configurations. One is essentially a ball shape, and we treat the area several times in that configuration. Then we change it again to what's called the flower configuration, where we again treat the areas again. We then move to the next location.
It is a same-day procedure where patients can return home and recover. After a week, the patient can return to everyday activities.
Great segment. Just to wrap things up about this newer technology with ablation, are there any people who really should not have an ablation? Are there contraindications to ablation for AFib, Paul?
Well, if they have a blood clot in the left atrium, then they would not be a candidate. I think people that have been in atrial fibrillation for a long time, such as many years, they are not very good candidates because it's less likely to be successful. If other methods have been attempted to keep the rhythm normal, maybe they have one ablation and not successful, then sometimes it's not that helpful to keep going with one or second or third procedures.
Got it. Yeah. So mostly the history
of
it helps you decide.
Right. And the size of the left atrium can make a bit of difference in how successful it is too.
Got it. So that might be why you do an echocardiogram before the procedure if they haven't had one recently. Okay, good. We've got a lot of other questions. We had, let's see, an email question. Is it normal for my heart to feel like it is racing sometimes and sometimes skip a beat? Happens when I'm not exercising. We kind of talked about this a little bit before. Hard to know. How would you advise this person if they're in your clinic with those symptoms? Well,
I usually tell the patients that we'd like to record your rhythm when you're having the symptom. And so kind of getting back to heart monitors, one of the things I do not uncommonly in my clinic is if there's symptoms, like let's say you want to put on a heart monitor and we know it goes for 2 weeks, but this person's symptoms only occur once every couple of months.
Yeah.
How are you going to get that,
Right.
So there's a couple of options there. Nowadays we've got smart watches with EKG capability, or there's these little things you can buy called a Cardia device where you can record your rhythm and it saves it to your phone, and then patients will send that to us electronically through the electronic health record, actually.
And
so those are helpful.
I got to back up because I want to know how accurate are the smartwatches and the home devices. Like, has this been studied? How reliable should I feel like these are when my patients come in with that?
Right, so if your patient comes in and they says that their Apple Watch said that they have AFib, and it's just telling them based on their pulse, then it's not. Then it's not that accurate. There's a lot of false positives, and that's done intentionally because the company doesn't want to not tell someone that they might have it when they could,
Right.
And so, but If it's got the rhythm tracing capability and it records it and you can look at it, it's a lead 1 ECG tracing.
Yeah, great.
And so that's good enough for me.
Good.
In fact, I can think of a case where a patient had intermittent heart racing symptoms. They weren't real often. She lived, a long ways away from Sioux Falls. She got a device, recorded her rhythm, and sent it to us. She was having a rhythm called SVT, which we then ablated and took care of it.
Awesome.
There's also implantable monitors that we have. They're little devices about the size of the clip on a pen that sometimes we'll implant in people if, say, you're passing out from time to time and we don't know, and it's not very often, and we're thinking, geez, could it be a heart rhythm problem? We'll implant those devices. So then you're monitoring your rhythm all the time. If you have one of these cardio devices or an Apple Watch, you're only taking a rhythm strip when you're doing it.
Good. Yeah, so for those symptoms, a heart monitor is helpful because we just want to know what is the rhythm while this is happening. Is it normal or abnormal? Yeah. We had an email question, could the doctors talk about ventricular tachycardia? So certainly a less common problem, but what is VTach?
So ventricular tachycardia is a rapid heart rhythm coming from the ventricles, the lower chambers. It comes on in a variety of situations. Some people can have completely normal hearts and still have ventricular tachycardia. Usually if it's not very rapid, then that's not very concerning, not very risky. It can be bothersome with symptoms. If people have heart disease, say they've had a prior heart attack, so if the heart is significantly weaker than normal, the ventricular tachycardia, if it lasts long enough, say 30 seconds or more, has a higher risk to cause more concerning symptoms, chest pain, short of breath, dizzy spells, passing out spells, even potentially a cardiac arrest.
Yeah, so it can be concerning.
It can be very concerning. So if people have significant heart weakness and they have some even short episodes of the ventricular tachycardia, it's certainly best to be evaluated, and sometimes that's when a defibrillator device is implanted, which is somewhat similar to a pacemaker, but a bit larger. And then the device can treat the ventricular tachycardia by delivering pacemaker pulses during the rapid rhythm, or if necessary, deliver a shock to the heart during the rapid rhythm to stop it and get it back to normal.
Yeah. So those internal defibrillators or ICDs, you mentioned, having one of these ventricular rhythms might be a reason to get one. What are other reasons that you recommend patients get these defibrillators?
Yeah, the most common reason we put a defibrillator in is just because someone has a weak heart and it hasn't gotten stronger despite surgery or putting in stents or giving them specific medication. Patients with weak hearts are at risk to have cardiac arrest. And if your heart's weak enough, then we say the risk of that cardiac arrest is high enough that it's justifiable to put a defibrillator. So that's the most common reason. Other reasons is if someone's survived a cardiac arrest, and it's due to an irreversible condition, then we can put a defibrillator for that.
Yeah, potentially life-saving though for patients, so great. Let's see, we had a question, what could be causing a recurrent tachycardia over 120 beats per minute when doing light activity in an otherwise healthy young person in their 20s with no other health concerns?
Often that's a condition called inappropriate sinus tachycardia. So there's a variety. Some of the things can affect the autonomic nervous system. They can change the balance of the the suppressive versus the more stimulating effects on the sinus node, the normal pacemaker of the heart, and that can cause rapid heart rates. And the most common group of people to have this are young, healthy women. Some often in the medical field, it turns out, which can be very bothersome, cause symptoms, but it's almost never anything risky, almost never serious. So one of the main treatments is reassurance. Another treatment is actually exercise. They find that regular, good, solid exercise program often lowers the heart rate. I guess we think of athletes often have slower heart rates than people that are sedentary. So they've done studies where they looked at heart rates in people that have this condition and they exercise regularly, and the heart rates do seem to come down when they can get into a very good, solid, regular exercise program. And there are medications that can be used if that seems to be necessary.
If they're symptomatic enough.
Symptomatic enough,
yeah. Great. Let's see, we had a Facebook question. What is the difference between PVCs and AFib. I have PVCs. Are they as dangerous and need treatment like AFib? So what's a PVC?
So entirely different.
Yeah.
So a PVC is a premature ventricular contraction, which is a fancy way of saying an extra heartbeat coming from the lower chamber of the heart. And PVCs typically, like, I think everybody has some PVCs. Some people have a lot more than others. And I typically tell patients that usually PVCs are not life-threatening. And typically we only do anything about PVCs as far as to try to suppress them if you're having symptoms or if you have so many PVCs it's starting to affect your heart function. That's another case where we'd have someone wear a heart monitor, and I like to have them use the 2-week one so I can see how much it varies from one day to the next. But really what we're looking for is how many of your heartbeats are PVCs. Because if you have more than 20% of your heartbeats are PVCs, it could start to affect your heart function over the long term.
Got it.
Not always, but it could. AFib is a rapid irregular rhythm of the upper chambers of the heart, so entirely different thing.
Yeah. And with PVCs, we don't anticipate any risk of stroke or any of those other things that go along with AFib. Everyone has some PVCs, right?
Seems like it.
And most people. Okay, good. Let's see. We had a question from Winner. This viewer's husband is on their 3rd pacemaker or, iteration of a battery or something like that. It sounds like they find that he's in atrial fibrillation a lot of the time, probably just with the data from the pacemaker. And the patient has trouble sleeping at night, she says, wants to know what can be done. Hard to know if this patient is having symptoms from their AFib, but you probably see a lot of patients like this in your clinic.
Yeah, a lot of the pacemakers diagnose atrial fibrillation very readily, so it can send in the information through the remote monitoring so we can see what it's doing. So if the person's having trouble sleeping because of the atrial fibrillation, then treating that with the rhythm medications to try to keep it normal, or slowing the heart rate down. Some people are bothered by the rapid heart rates, so if we use certain medications to slow the heart rate down, then they're less bothered by it. And then sometimes the ablation comes into play there too.
Yeah, good. So maybe treating the AFib.
Treating atrial fibrillation if that seems to be the cause, correct.
Okay, good. Let's see, we had a few questions. I apologize to our viewers who I am not asking if they're not really heart rhythm questions, but scrolling through, we had for arrhythmia, what would be the best medication? And how I guess, let's just back up. We kind of talked about AFib and all the options. How do you decide, like, in this individual patient, what is the best treatment for you?
For AFib?
Yeah, let's talk about AFib.
Well, so a lot of it comes down to how much of the time are they having it. Okay, so we have some patients that have AFib once a year. And there's a medication sometimes that we'll give, we call it pill in the pocket.
Yeah.
So you have your AFib. If it doesn't stop within a half an hour, they take the medicine, and about a 70% chance it's going to help terminate that AFib. Then they're good for the rest. So they don't have to take a medicine all the time.
Right.
Sometimes patients, if they have AFib more frequently, then we might start to give them medicine more scheduled. If the patients don't tolerate the medication, or they don't, so in some cases if they just don't want to try the medication but they have symptoms from their AFib, then we do move on to the ablation procedure.
Yeah.
How do we decide which medication? That's a complicated question, but it depends on what else is going on with you. Have you had heart attacks before? Is your heart function normal? What's your heart rate when you're not in AFib? That kind of helps us decide which medicines are most appropriate for those patients.
Yeah, really individualized,
Very individualized,
this
yes.
particular question, right?
Yeah. There's guidelines that give some recommendations about which way to go, but heart weakness, heart attacks, certain medications can be used. Normal hearts, several medications can be used.
Yeah. We had another question just about a sleep study and heart health. And we talked a little bit about sleep apnea as a risk factor for AFib. Why do we think that is? Is there any theory about that?
Yes. So sleep apnea causes, so the airway obstructs, the oxygen level goes low. So then when a person's asleep, they're breathing against a closed airway, which puts a strain on the heart. So it's like the chest is trying to expand and they can't open up the airway. So then the oxygen level goes low and it activates like the sympathetic as well as the parasympathetic nervous systems, which cause changes in the atria. And so there's some electrical and structural changes that occur in the atria, the upper chambers, that promote the occurrence of atrial fibrillation. So people with sleep apnea over a longer period of time become more susceptible to atrial fibrillation. And so it doesn't necessarily have to happen at night when they're having the obstruction. And then there are studies that show that people that can, if they have significant sleep apnea, use their treatment, the CPAP or BiPAP or whichever type, that if they can use that consistently, that will improve the success of the medicines or the ablation for controlling atrial fibrillation. So it is very important to be able to try to treat the sleep apnea when people have that.
Yeah, so something that you actually think about when you're trying to treat their AFib might be...
I discuss sleep apnea with just about everybody that has atrial fibrillation, and often recommend a sleep study because it certainly is something that they can do to really improve the success of the treatments that we're going to try to help them with too.
Yeah, great.
One thing I'd add there is that people, when Dr. Olson recommends a sleep study or refers to consider that, people think of historically you have to go to the hospital and get hooked up to a bunch of machines. Nowadays, they most often do these home sleep apnea tests where they give you some equipment, you take it home, and you wear it, you sleep in your own bed, take it back the next day, and they're pretty accurate at discerning, like, do you have a sleep disorder and how bad is it?
Yeah, we use home sleep tests most of the time now, and I would just say a plug. I think we have a whole show about sleep apnea coming up this season on the show, so if you want to learn more about that, tune in. But it's great to know that it's important for at least this portion of cardiovascular health. Great. Well, I really appreciate the time here. We talked a lot about heart rhythms and that kind of thing. We had one more email question I'd like to hit. What role does heart rhythm play in the ejection fraction? We've got under a minute, but we've talked about a weak heart. Right. Can the heart rhythm affect that?
Absolutely.
Yeah.
So two things that come to mind right away are persistent rapid heart rates.
Yeah.
So AFib, atrial flutter. If the heart rate's too fast for too long, and usually that's several weeks, the heart function can start to decline. I tell people it's almost like the heart's starting to get fatigued.
Yeah.
Then the other one is if you have a lot of those PVCs.
Got it.
If you have like 20 or 30% of your heartbeats are PVCs, sometimes we'll see people come in and their heart. Actually, sometimes people will present with heart failure with these types of rhythm disorders. They come in short of breath, and they lay down, swelling in their legs, and they're unaware of the heart rhythm, and because the heart rhythm abnormality has been going on long enough that their heart's gotten weak from it.
Yeah, great. Our winner is Kelly. A book will be sent to you shortly. We'll be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
Olson and Dr. Adams for volunteering their time to help us learn more about cardiovascular rhythm and how it relates to your heart health. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m., and be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Respiratory diseases are a major cause of mortality and morbidity worldwide, but the situation is not hopeless because most major respiratory illnesses are avoidable. Tackling the burden of lung diseases. Next time on Call with the Prairie Doc.
Hi, my name is Joni Holm, and I serve on the Healing Words Foundation Board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,